Before we begin our seminar today, I just want to remind everyone that in the department and in the school, we're seeking to bring speakers with diverse experiences and perspectives. And as a reminder, they are here to share their own insights and don't speak for the department or for the university. And with that, it's my absolute pleasure to introduce my friend and my colleague, Dr. Anya Vieira, who is a senior researcher at Cruz in Brazil, and also here at Harvard, a fellow at the David Rockefeller Center for Latin American Studies. And we'll be giving a talk on community health agents' experiences with violence.
Good morning, actually, good afternoon, everyone. Thank you for being here. Very happy and pleased to be in this house talking about the impact of violence in community health agents or workers in Brazil and some policies implications. So before talking about it, I need to give you some information regarding our health system and the way things and violence in Brazil. That's where we started. Brazil has a unified health system called SUS. It's free of charge, it's integrated, it's universal. It is for everyone that is physically in the territory of Brazil. So even if you're a foreigner, if you're visiting the country, if you need health assistance while in there, you're able to achieve. The way it's organized is to a net of services, and at the base or the most important of it is on our point of view is the primary health. Primary healthcare in Brazil is then organized through health teams. If only we have these parts of the word. There, those teams are composed of a medical doctor, a nurse, a dentist, health auxiliary, and community health agents. The community health agents are people from the community that have been trained in health, and they are paid by the government as part of the team. And they're responsible for the liaison between the community and the health units. So those are the ones who knock on people's doors saying, oh, are you pregnant? Have you been to your prenatal care? Oh, you have a child here who is 3 years old. Has she taken all the shots? Someone has a coffee, hasn't stopped for 3 or 4 months. Thinking the TB. Oh, the person doesn't want to go to the health unit. He knocks on the doctor's house, or the doctor's door, and said, you need to go and visit this person. So he is the liaison, very important one for our health system, because he understands the community as he is part of it, but he also understands the health system, and he does this liaison between the two places in a very specific territory. So each health team that I just mentioned is responsible for about 3,500 people, and each health agent is responsible for about 750 persons in a specific territory. So he will know where the church is, he will know where the health unit is, he will know where the school is, and understanding this territory, living on it, that's very important for what he's doing of that. Sadly though, not only in Brazil, but in Latin America in general, and I bring here some data from 2013, so more than 10 years ago, showing that in spite of Latin American had increase in a lot of income, trades towards the world, violence is still a very, very important issue. About 10 years ago, as you can see, out of 18 Latin American countries that were analyzed, 11 had homicide rates higher than 10 per 100,000, which means, according to the World Health Organization, an epidemic level. So that was, and it had only got worse, unfortunately, throughout the time. The growth of dissemination of crime has increased fear among citizens, and murder rates in the region had grew at 11%. And Brazil, as I said, is not out of that. There is a non-governmental organization in Mexico that every year ranks the 50 most violent cities in the world. And this year, out of 50, 11 are in Brazil. And of those 11, 10 are in the northeast part of the country. Of those, 6 are state capitals So 9 of the state capitals in the Northeast part of the country, 6 are among the 50 most violent cities. And you can think, well, that's very new. No, in 2019, it wasn't different. So just for us to have an idea of how this distribution goes, we can see that the violence here, North America, South America, and South Africa, that's mainly where this is. And if you remember that data that I told you, the 10 deaths per 100,000 as being an epidemic, the rates we are seeing here is 110, it's 50, it's 60. And in the northeast part of the country, where in Brazil, by the way, I forgot to say that Brazil is divided in 5 different regions. In the north, where the Amazon River is, or the Amazon forest and river is, and the northeast are the poorest ones. But the northeast is the most densely populated. So that's also where the violence has increased more drastically throughout the last years. So that's the area that we are working on, that we've been studying. So then, throughout that information, we decided to look at to see how does the urban violence affect community health agents' work process and mental health. And while we were doing that, COVID stroke, don't know, was there, is there still. And we had also to put that on board and to analyze the data. I have to say that we don't do anything by ourselves in this world. We don't do a research like that either. There are 8 of the Brazilian colleagues here today, and I'd like to thank them. We do collect data on those 8 different municipalities, 4 state capitals. Of those 4, 3 are among those 6 that I said they're among the 50 most violent cities in the world. We have 4 cities in the inner part of the country, not capital. So I thought it would be interesting to see what's going on the smaller cities that are not so exposed to urban violence. So that's the decision that we had. And we collected data in 2021 and collected data in 2023, quantitative data, and that's the data I'm talking about today. We also collect qualitative data in 2022. We collect data in 2019 before COVID. But today we're focusing on part of the data we collected in 2021 and 2022. So I think I've talked enough about context. Let's see the results, right? About socioeconomic demographs on the community health workers. In average, they're 46 years of age. They've been living in the community for 29 years. So they really know what's going on there. The majority are female, about 82%, and they either have high school or university degrees. For Brazil right now, they have to have high school in order to be in that job, but in the past that wasn't so we still have people that don't have high school. But some of them already have university degrees, and that's for us important because it helps them develop these. When we talk about professional information, 85% of them live and work in the same community. 10% work and live in urban rural areas. And in average, they've been working as community health agents for 16 years. So it's not that they're new on what they're doing. They've really been there. They know the community. And about 60% of them believe they work with what they're supposed to do. Let's talk about violence. And when we asked them, we saw that 43% felt threatened by violence during their work. 18, almost 19% of them thought of changing jobs because of the violence. And I think most important, 28.6% of them stopped caring for families because of the violence. They stopped knocking on people's door, stopped doing what they're supposed to be doing. And we'll see soon that this is happening more in the most vulnerable areas. So it's making the inequity even a bigger problem. 56.2% of them believe the violence interferes with their work performance. And when we ask them if the violence affects their mental health, their physical health, and we can see that 41% believe it affects their physical health, and 64.7% affects their mental health. It's not a little bit, it's there. and living and working on that environment to make things easier. But I told you I also looked into the COVID. What are the data for the COVID? So when we collected this data in 2021, about 80%, four out of 5 community health agents were on the front line for COVID, but 83% of them, almost 84, did not receive any training. And when we asked about if the COVID affected their work process, 80% said yes. And when we asked if there was any relationship between violence on the territory and their work in the COVID, 18% of them said, yes, violence influenced my work process, which again makes these vulnerable areas, which in general were also more affected by COVID. Talk about work process, they do, let's say what they're actually doing there in the field. They do a lot of things. Those, I would say, are the core of what health workers do. So they do home visit. In a little while, I'll explain different types of home visits. They do health promotion activities in the community. They do school health programs within the schools. They do service in the community. They do health promotion activities within the health unit. They do bureaucratic activities, of course, among others. And when we ask them if they were doing or not, we didn't ask the frequency here. We'll do that in a little bit. We just ask, are you doing those activities or not? You can see that in 2021, in general, they were doing less than in 2023. And for that, we think COVID was the most important issue. Other things sometimes you couldn't do, not completely store. And you can see an increase on the doing or not doing among the treaters. When we looked specifically to see the different types of home visits, because they can go to a visit in a house by a demand. Someone went there to the health unit and needs someone to come to the house. We have an elder person there, and it needs to have attention. So the health agent is the first one who gets there, see what it needs, and organize with other professionals to come to the residence through their period. They come for family registration on the health unit. They come to do active case search, as I said, prenatal care, shots, and other things like this. They come for specific programs. In Brazil, they're also responsible in certain parts of the country to see if the children are getting into some of the milestones at the right age, and if not, some of them are actually doing some work within those houses to actually improve that the environment in the house is a good one so the child can thrive. I think that's the word. I hope you understood me. And they also, it's not on their core, and that's supposed to be what they're doing, but also together with doctor nurses and the house, mainly because the doctor nurses and dentists would not feel safe enough to go somewhere else house if they're not accompanied by the health agent. And it's the same to deliver medication. It's not on the core of their activities, but they do it because sometimes it's hard for others to know. And you can see it again, there is a huge increase between 2021 and 2023. But then we ask, okay, so comparing to the frequency you do now to what you used to do before COVID, has the frequency increased, decreased, or maintained? You can see that in orange for all the different activities. At the end of the year, the decrease bar is higher in all of them, showing that in spite of now doing what they were not able to do in certain areas due to the COVID in 2021, they never went back to doing the amount they used to do. And I have to say that not that they were doing enough before COVID. You know, we had already a lack of problem. We can see that from all the work processes. And we decided to look into their mental health examination. And we looked into specific or SRQ. She looks into the risk of mental disease, like anxiety and depression. We noticed that 40.5% of them were in risk of mental disorders in 2020. When we looked into the different domains of quality of life, looking into the so-called REEF, which is a health organization, we saw that the environmental domain is the one that they have lower quality on, and is related exactly to the environment they live. Again, when we look at that throughout the 2 years, comparing the 2 years, we can see that in general, there was an improvement on quality of life, but on the psychological domain, we decided to look at other factors also that might have a relationship. We all know that we are in a hard situation. If we have good social support, if we have good self-efficacy, if we're not, we tend to thrive better, we can. So we decided to look into that as well. So this is social support for them. We saw in both years, family, friends, other significant in the total. And for us, I thought that social support would be better in 2023 than it was in 2020. This is quite a while ago. And we haven't tested, don't know if we'll be able, is that through the times of partnership is when people get closer together. So we're thinking that the COVID helped somehow people to feel connected. That's the core, I can say that, of COVID passed, then everyone went to their own space, and that social support. When we looked into the SRQ, you can see again that there is a decrease on the risk of mental health disorders. And I have to say that this is all hair analysis. So there are same health agents in 2021 and 2020. Interesting, I don't have here the data from 2019 because we only collected data in one municipality, but risk for mental health was roughly about 22%. To 40% that was heavy, and 2 years later, it went a little bit down to 38 something. I never down to 32. And I'm not saying that 22 is a good number, it's actually quite good. If we looked into people that are in prisoners, and they tend to have prevalence lower than that. So they are really living on a stressful. If we look into self-efficacy, I slightly increased. And if we look into anxiety of corona, there was a decrease as we expected. Some of them have not stated yet, as much as we all know about COVID. So I think it's kind of natural to see the decrease. We decided, and we thought it was very important to look into geographic things more especially distributed, and here's just one of those 8 municipalities, just for the information. For Cruz, which over there you can see the little dots are where the health units are. There's 160 units, which is 2.4 million inhabitants there. But you can see that's pretty much well spread. I can assure you those rural areas is where we have more health units. It's divided in 60 regions. And when you look into the top 2 maps, the first one is you consider the neighborhoods you live in. And the second one is, have you seen violence on your neighborhood? And you can see that regional 1, 5, and 6 is easier to point out, but it can be on the same path. Regional 1, 5, and 6 are consistently shown as those places that are more violent and that they're seeing violence going on. And then when we ask down here if the violence interferes with the work, again, you can see very clearly that's the same path. Did you stop caring for families because of the violence? And again, of course, but you can see the same they'll say, okay, that's what they're saying. What is the reality? How is the violence really going on that area? And then we get data from homicides from 5 years, from 2015 to 2019. I know violence may not homicide, but I guess it's a good proxy, let's say. And again, you can see that regional 1, 5, and 6 very clearly showing that those areas, which are, and I am from this hometown, so I know that's where the lower developmental indexes, that's where we have more problems with robbery, that's where we have more problems with kids in bullying schools, and that's where even health professionals stay longer on the health units. It's harder there because for hurdles, no one is injured. So, and funny enough, is where we have the highest coverage of health units and of health agents, showing that in spite of what you're trying to do, in areas that they need the most, because they're more dependent of the unified health system, is where the health professionals are having the harder time to care for their work. Trying to understand how all those things kind of got together. Spent a few months. Years I need to thank Aisha because Aisha and Dr. Masakastro are part of this project for a few years now. But trying to understand how all those things get together. We ask a series of questions for health agents. For example, have you seen someone screaming at each other? Someone being robbed? Someone being stabbed? Have you seen a fire, arm fired? Have you seen someone being shot? Have you seen anyone being killed? Have you seen someone or heard about someone being raped? So we divided that on heard or saw something about violence or suffer violence. And the suffer here is either the health agent itself, herself, or someone on his immediate family. And we saw that this relates, of course, with each other, but also with their perception of violence. Because perception of violence is even real violence. I can live in the same municipality as you, and we perceive it different. One of the things we've noticed is that older health agents with lower schooling, they tend to perceive less violence. And I think we believe that has to do with them normalizing that that's how they grew up. Someone, other child in this in the middle of the street, or they're educating their child, is not spanking their child. So the way you perceive it has to do with this, seeing it is related to the perception of work. On this side here, we have the risk of mental health disorders. And this relates to perception of violence, exceptional violence relates to that. So there's a two-way error right here. As we collected this data during COVID, we thought it was important to see COVID information. So there are questions like, did you get training? Did you get enough protective gears to go work? Get vaccinated and things like that. So we saw that this relates to the side of corona, which again relates to the mental health. And if you look into the perception of violence, it has, together with the COVID and in the mental health, has effect on the external activities that are developed by the health agents. And here it's important to understand that, so you remember all those activities that some of them are performed within the health unit, and some are then are done in the community. The effect is on the activities that they do out there in the community. For us, showing that it has more to do with the context that the community is, the violence, or violence there's. And then when you see this, you think, well, okay, so we understood all, we understood this is a homogeneous group of people. You think about policies and what you do, but we decided to look into them a bit closer. And we found out that there are at least 3 groups of pages. Very fast, I will try to explain. So we have one that's highly educated or educated, younger, have been in our work for the last time, they tend to do more of those activities that show. They do feel the violence very hardly and they suffer with it. The other stream, we have health agents that are older, not as highly educated, to most of the activities that they're supposed to, they don't receive as much violence. They feel their violence affecting them as much as the first group. And then there's a third group, which is smaller in number, but is an important one, because they're halfway in age, halfway in scholarity. They're the ones who don't go to the community. They felt they don't do it because they fear that they don't feel. They don't fear as much. So we don't know if they don't fear if they don't go or they don't go. I don't know. But the fact is that we have this third group there that, so here's them doing the activity. Here's them. You can really see the difference here, but this group doesn't feel as much the violence and doesn't feel the burden. So this roughly is the data that we have, but as a group, we believe very strongly in a couple of this, that we can't just do innovation, which is the data, get information from places like this. We go to conference, write papers, we have to go do that. After all, we are advocacy. We do advocacy on health system in Brazil, on primary healthcare. So we decided to do things that first were not on the description of the research, but as a research group, felt very strongly that we had to do. There is some of the timeline of the things we do there. Now I want to call your attention to this line here, which is strengthening research, the research group and its relationship with stakeholders and community health agents. And to do that, we have done a series of things. One of them is we went back to every one of those respondents. We invited health agents, we invited health secretariat, we invited professionals from the primary health care to see the data. And at the end of the presentation, just made in a sort of workshop, we asked them, you see yourself. Is this going to be representative of what you live on? No, but what do you think it needs to be done? What can be done to help you? And of course, the answers, of course, but the answers were yes, we just see ourselves there. This is really the reality that we live on our everyday. We want this violence to stop. We know that this is easy. So we need at least two other things. We need to better know how to deal with the violence, how to, when I'm in a violent environment, what to do. So I need to be better informed. Also, we also need someone to take care of us, or learn better how to care for ourselves. So then we did an in-person pilot course of facing the violence. And there we started and that was in partnership with both of you, which been working on courses like that, but related to school kids. It's the first time for no babies. And there we worked with a restorative approach on non-violent communication, all sorts of peace development. And so for 8 weeks, we had a day a week every Friday. And just before I took the course, we did a lot of questions. Right, and 3rd and 4 months later, we're very pleased to see how well they perceive this course. It's not hard to do, it's effective. They keep saying it helped me professionally, but moreover, it helped me personally. And what we're doing right now is we bring this course and showing to the ones out saying that according to them, it doesn't resolve the issue, but it helps. The other thing that we're doing right now is struggling to finish this project, but is an online course on self-care. There we're taking activities on how to meditate, how to have a good night of sleep, how to do a self-massage, how can I better care for myself. So caring for those who care helps them care better for those who aren't. So that's the idea. The idea here is to have this online course, and they can do the course. They can just pick whatever they wanted. WhatsApp is huge in Brazil, so the idea is to have in a format that they can send to one another the little, oh, I like this one. My mother will like that. I'll send it to her. So that's the idea what's behind this. Of the year to have that free of charge, of course, for any health agents, but it should be free for them. We're also doing an atlas on violence. So part of the data that I showed you on Fortaleza, we have way more. We have that for all those activities that I told you information. So we have about 18 maps for each of these atlas for all municipalities. But again, the year 2024, we're hoping to be out there as the aim of helping those that are in the future and that would be aiming at the health professionals, anyone interested on, but also on health secretariats or stakeholders that will better understanding, they will be able to do more sensitive to the needs of the website. Some of the data I show you, I think you recognize the graphs, right? And it's imperative. So you can go there and press this state, and you get the data from that specific state, or you can go to the home for states that we're in, and you can get information from all the data in 2021 is right there. The data on 2023, as we just finished collecting it in December 2022. It was there by now. It will be there hopefully. That's something that's. We also created some graphs. I know it's kind of old-fashioned. Read something in paper, but it's really working because you take it to the health units, you take it to the municipalities, health secretariats, and the people when they get into the unit to go for a dental appointment or whatever, they can see what's going on. I have to say that it's been very last year, feedback days. They said people keep coming to ask us questions, keep coming here to do research, but I don't remember anyone coming here asking things about us and worried about how we are and how we individuals work better, not especially not when we actually try to give you some tools. YouTube channel with videos, even in English subtitles, so I can give you guys the link if you want to. Wish I could spend here, but there's like 10 minutes late long. I should. So we'll start. So it's there. Of course, we have project meetings, and as we spread to all those municipalities, there's COVID, lots of Zoom meetings. We also get together to plan data collection, to analyze the data, and to organize our work. It's very important to say that we have within our teams health agents. The state and the municipalities that are responsible for the secretariat, because it's not only researchers, investors. Of course, we are the majority there of researchers, but having them together with us from the beginning, it has made a difference. Even on the way, how to give feedback, how to understand the needs, how to plan the future, how to analyze. Sometimes you think, oh, this data is showing this, and then the health agent said, oh, hey guys, remember this, this, and that. So, as I said, in 2022, we collected qualitative data, and there's a group now responsible in looking to impact qualitative data. 2022, workshop, or if we go to conferences and congress and meetings, we come here and we're very happy with that. And of course, we also publish articles. There are a few of them already published. There are other few on the go, waiting for answers. There's some that is being written as we speak, literally. So there's not a lot we can stop and what the future waits us, or what we've been thinking of doing in the future. So first, and there's not only this, but analyzing data. Can someone on the other side just let me know if you can hear us, please? Yeah? Okay, cool.
Thank you so much. Can you say a bit about the sampling strategy of the committee of workers, or what's the census in the selected cities and response rate? I suppose it was higher, I'm not sure.
The sponsors? Yeah.
Response rate.
As I said, there are a few sponsors. Oh, sorry. Sponsors, okay. All right, so in 2019, the data I didn't show you, which was only one municipality, and Ana Patricia, who is here, was doing her postdoc on this data. We tried to do a census. So in Fortaleza, who has about 2,000 health agents, and we were able to collect about 1,500 health agents, the data. For 2021, then we did the sampling, and the way we calculated the sample size, and the sampling was, as you see, I'll explain in Fortaleza, but it's very similar to all the other places. We wanted it to be have data from all the different regions. So knowing the amount that we needed and knowing how many health agents were in each one of those, we knew roughly how many we had to take from each one of those regions. We then, knowing where the health units were, we literally old-fashioned, not computer, put all the names of the health units, took sample also to know how many we needed from each one of the regions. And then we went there and we collected data from the health agents that were there. And to collect the data, the questionnaire was huge. It's like 16 pages. So we normally invited health agents to be in the health unit for that specific time. As you see, they most of the time are in the field, but they tend to come early in the morning to the health unit to see what the demands are and everything. So we would talk with the manager of the health unit. We invite the health agents to be there. We would then explain the research, get the consent form, and ask them to fill up the form, while one of us, or one of our data collection, some of what was there throughout the whole time. So if they had any questions, and also it was harder for them to leave if there's someone there waiting for a train to get the questionnaire. And that's how we collected data. So it was we are actually, I have to be honest, normally the ones who got there answered. It was hard to say no to our data collector faces. One or other would say, I need to go now because I need to see a patient or whatever. I don't have the numbers because, again, I don't know how many were invited and then show up, you know, but in general, we didn't have a lot of people saying no, especially on the second run, because on the first run, for them was just one more research. For the second run, they kind of knew us already because we had done all that activities. So the research, the second run was better. We didn't have a lot. I can't precise you the amount though, I'm sorry.
Congratulations.
Oh, thank you.
I was very curious about the second profile that you mentioned. Of health agents that didn't fear going into the field, but also didn't go a lot.
The third one, you see.
That was the,
Yeah, because the second one was the one who did do most of the activities, but didn't feel much of the violence there.
Yeah.
And we think is that as they're older and they've been there for longer in general, they're just used to it. And the people in the community also know them for longer. So they feel part of it and they don't, I think also when you get older, you start maturing, I guess,
And then, so how this affects you in a different way. So, but the third profile was the one who didn't do the activities, nor felt as much the violence, nor felt were in the less frequently were in a risk factor for mental health disorders.
Do you have like some profile in terms of demographics of that group? Like who are these people? Why do you think that happens with them?
Okay, we're actually writing a paper right now on that. And we try to understand those three profiles to a lot of things. They are more commonly in the bigger municipalities, Fortaleza and Recife. I don't know everything by heart, but I'll try to speak out what I remember. We believe those are the ones who, I don't want work. Sorry, that's it. They pretend they pay me, I pretend I do something here, and but it's just, they are not, I would say, they are not truly tailored for the work, but that's a job. Okay, so that's my feeling, and take that and as a bias, like, we are here because it's a job, but that's not my life. While for the other ones, being a health agent is their life. And that's also what we hear from them, because as you live in the community and you work there, you're not health agents from 8 in the morning to 6 in the afternoon. Like they keep saying, at 3 o'clock in the afternoon on a Sunday, I'm there with my beer on the bar, and then someone knocks on my shoulder and say, hey, by the way, can I come tomorrow morning to the health unit to do this, this, and that? So they are 24/7 health agents. But I think we need, and I hope on the qualitative data that we collect in 2022, get more info on we call them nenéns. You will understand that because I know you're Brazilian. We have an expression for teenagers. It's a horrible one that says neném. They don't go to school and they don't work. So we nickname those group as the nenéns. They really don't go to the field, so they don't really feel that much of what the field is. Oops.
The violence.
Mhm.
I don't know much about Brazil or something related not that part related to that how much when the kind of health worker are pulling off from the field. It's about like getting to place, it's not just in the family, the dangerous family. I don't want to
Yeah. Yes.
How they develop
Especially in the northeast part of the country, and coming from the southeast, in the past, like 15, 20 years ago, what I'm describing now in the northeast, it would be common in big cities like São Paulo and Rio. But it's mainly armed groups related to drugs. Brazil is not huge producing drugs, but it's very good on spreading it to the rest of the world. And in the northeast part of the country is the closest one to Europe, to North America, to the east coast of North America, to northern part of Africa, from where the drugs will go to Asia and stuff. So these violence, the violence that I'm talking about, it's more related to that. And I'm not saying that we don't have domestic violence. We do have structural violence. We have all kinds of violence, but the ones here more. So what happens is, as police and a lot of policies were done in the southeast area of Brazil, São Paulo and Rio, a lot of those armed groups went out to the northeast. And there now they literally, you get the city and they'll say, this neighborhood is owned by this group. This other neighborhood is owned by that group. And when they're trying to get new areas, literally there's shootings, there are fires. I was a dentist. I'm a dentist, by the way. I was a dentist at the health unit in 2006 for about 6 months. And I do remember that, so it was like almost 20 years ago. And I remember back then, I was in a very nice area of the city, not on those violent areas. And I remember being there, and not only once or twice, we'll see fireworks And everybody knew that it meant is drug coming in. And it means that we couldn't leave or get into the health unit at that time. Whatever we were, we had to stay. And we waited for like a half an hour to then be able to move around again. It only got worse. So the police trying to fight those, again, there's a lot of shootings, and the violence gets to everyone, to the citizen that has nothing to do with it, to the kids that are going to school with their backpack and is shot. Not long ago, there was a person who had their umbrella, a black one, on the backpack. The police thought it was a gun and shot the person. It wasn't not doing anything. So that's the kind of violence we're talking about. It's homicides and between armed groups.
Could you please talk a little bit more about the status of the healthcare agents? Are there voices or the opinions reflected in the health community health activities and health policy making?
Okay. So they have a very good sindicato. How do I say that? Union, thank you. They have a very good union, which has been good for them on the sense of their rights, money-wise, and the organization too. I have to say, though, that theoretically, when the team gets together to plan what they're going to do, and the way and I forgot to say that, the way that our health system is organized is that primary health care is responsibility of the municipalities, on the idea that they're closer to the people and better able to adjust the activities that are being done depending on the needs of the population. So if you're in the middle of the Amazon forest, you can see that the needs are different than in your big city. Or if you're in a territory with young people, prenatal care and vaccines will be the most important things. And if you're in a territory with more older population, then chronic disease and the elders will be. So because of that, on the paper at least, the health team is supposed to gather in a continuous form to plan their activities that they're going to do. And the voice of the health agent supposed to be there doing it. And we hear, though, that in practice, sometimes this works wonderfully, and the health agents feel that they are responsible. And I've heard from doctors, nurses that thank God we have them because they really know what's going on, and we couldn't plan our activities if we were hearing them. But there are places where it's just the doctor, the nurse, sometimes the dentist get together, pretend they're planning, half an hour meeting, and there we go. So it really depends on time to time.
Yeah, you mentioned at some point that the recruitment, the committee health workers, there was a change that before they didn't have, if I understood right, that they didn't have any recruitment, and now that it's required that they graduate from high school. I was wondering when that happened, and did that affect the recruitment of the committee health workers? And is that a national policy?
Yeah. So one step back, so to explain why. So the health agents, the health agents started in 1987, before the health teams were there. And the way it started, it was literally doing droughts back home. There is no food in the rural areas. So very commonly the federal government or the state government would give money for the men's to build roads and stuff. So like this, they could pay for food and they would survive, literally, the droughts. And in 1987, and I'm proud to say that, in my home state, the health secretariat thought, well, a lot of kids are dying. We also need to find a way to enroll women, because there are a lot of women and families that don't have a male there to get the. And then they decided to train some of those women that had kids on basic things related to health, like how to hydrate, if there was a diarrhea on the child, how to clean the umbilical cord, how to prepare food for the child. And with that, the children mortality rate went down very, very, very strongly. It was such a success. Our home state got a lot of prizes, and then the whole country started looking like, oh, that's a good idea. And then it became a national-wise action. And at that time, they didn't start saying that you had to have at least high school. A few years later, when the program, now strategy of the family health team started to work, they said, okay, you guys have to have at least high school level to be able to care for those. But those who were already enrolled continue. And that's why there's a small percentage of people there that still don't have high school degrees are the really old ones that were there from the beginning, even before the health teams, because they kept working, and sometimes even with not high school, sometimes they do even a better work because they really been doing that for a long time. Is it clear?
Yeah.
Okay. Okay. Oh, okay. Here?
Yeah. So nothing, okay.
No? Okay.
So just before we close, maybe I could just ask one quick reflection. You know, when you think about sort of depressive symptoms with and some of the strategies, the interventions that they put a lot of responsibility on the community health agent themselves. Based on some of our discussions and reflections, what do you think is the responsibility of the health system in terms of strengthening them?
I fully agree with you. I don't know if everyone heard what Aisha said, was like, we are putting all the burden even to care for themselves on the health agents, right? So how about the health system? There are a big array of things that are going on. Some psychological support groups, especially because of the COVID, from all professionals, health professional teams. And I fully agree. And I think that the secretariats need to have a space and a way of caring for the health workers. Here I'm presenting data for the primary health care and specific for the community health agents, but that's the reality for a lot of the health workers, especially on those violent areas. As I said, I've been there 20 years ago in a nice area, and I have to be honest, there were times that I was scared. One of our students the other day, who is a medical doctor, a woman came into a consultation and said, I want prescriptions for, oh my gosh, black target label that, control. And he said, no, but you don't need it. I'm not giving it to you. And she said, yes, you will, she said to him. He said, no, I will not. And she looked at him and said, oh, you're new here, right? Okay, I'll give you 24 hours. I'll be back here tomorrow and you give me the prescriptions. And she left. And the doctor went out and said, what's going on? And then the people, the community health agent looked at me and said, look, she is the wife of the main armed guy, the chief of the armed guy in the area. What she's saying is, if you don't give it to her, she will probably kill. It's not she will empty your tires. No, she will kill you or whatever. He said, I will not do that. Like it's against my will or something. And then talked with the health secretariat. And what they did, they pulled him out of this health unit and put him somewhere else. But then the next guy will come, other prescribe or whatever. So it's not an easy task. It does need to be, things need to be done. There are, like the UNICEF has a safe health unit program that some of the municipalities are implementing, which it's like giving signals to the health team what's going on outside of the health unit and within the health unit through little, for example, little plant, fake one, that if it's all green, it's fine. If it had an orange leaf, it means attention, there's something going on the territory. If it has two orange greens or two orange leaves, it means that attention, there's something going on within the health unit. If it has a red, so, but instead of everybody screaming at each other, like signaling and trying to make a better or safer environment. And I also need to say something that like it looks like the population doesn't like them. It's quite the opposite. In a lot of times, health agents are the only face of the state that a lot of those communities see, and they are respected. That's why they still be able to do some of their work in spite of all what's going on. But it's getting harder and harder for them to do that. That's why I think they need the support to.
Thank you.
Thank you. I need to thank all the team that's here as well. There are 8 Brazilians coming all the way from there to spend the week here.